what you wish your doctor knew about autism. That's what we're going to be talking about tonight. And at the end of the presentation, we'll have some time for questions. Those of you who are attending virtually want to put them in the chat, that would be awesome. And if anybody who's here wants to raise a question, just your hand, if they're easier to see. So let's get started. Of course, now my laser pointer isn't working. Can you take that out, put it on the other side? We'll get going in just a second. I've included 3 carefully prepared errors in this show. So see if you can find them all. All right, we're going to do this by me pointing at you and you advancing the slide. Maybe. Yeah, there you go. Perfect. All right, so why should you care what I have to say? Let's start there. I have been a mental health nurse for 24 years. The last 10, I've been working mostly with autistic clients. I worked in a 28-day dual diagnosis program that was a state hospital, pediatric mental health inpatient hospital that serviced clients with IDD. We took kiddos from 6 to 17. I was a camp nurse at a camp for people with autism for 4 seasons or 4 summers. So it's 7 weeks of programming, and each week is a different level of functioning and a different age group of campers. So as the camp nurse, I was checking in everybody's meds. So I got a real good opportunity to see what people were on and then to see behaviors that people were or weren't having. I was a care navigator for the innovations waiver. For those of y'all who aren't local to the Asheville area, this is a version of Medicaid. It's got an unfortunately long wait list. The average is 8 to 10 years. But yeah, I did that for a couple of years. And this was my favorite job, emergency room behavioral health. I did that for 3 years at Advent Hospital. And it was a really fascinating interface with the fact that I'm the only behavioral health person in the ER. Everybody else is general med surg, nurses, doctors, CNAs. And what they were doing was so dramatically different than what I was doing. And it would be, stuff would happen like where someone who we call frequent flyers, hopefully that's not offensive to anyone, would come in. This one gentleman came in with chest pain. They literally told him he was having a panic attack, and they didn't even call me to come down and do a consult. They sent him home. He came back 3 hours later, and the heart attack was shown on the EKG then. So they admitted him to our medical psychiatric unit. But yeah, so being on the spectrum or being someone who has frequent mental health problems, it's hard to be heard. We're going to talk a little bit about how to get people to hear you better. Right now, the last 8 or so years, I've been doing one-on-one coaching, public speaking, and trainings. It's wonderful when I get an opportunity to teach people about autism, as well as having the experience of being a nurse in these settings. I also have a level 1 autism diagnosis that I got in my 30s, I guess, so it was a late diagnosis. I obviously struggled my whole life and not kind of known why things were so hard and why like what worked for other people didn't work for me. So it was both a relief and a struggle to get the diagnosis, but I definitely have experienced a life as someone on the spectrum. You advance. Okay, these are the disclaimers because you always have to have disclaimers. This presentation does not contain medical advice. The only things to ask your prescriber about if adjusting your mental health medication isn't helping your state of mind. I also suggest that these are things anyone on the spectrum has a care advocate that goes with them to doctor's appointments and also helps them plan what they want to accomplish during the doctor's appointments, because doctors tend to speak quickly and over us. That's not about autism necessarily, that's just one of the barriers to care. I'm a nurse, which means I can't prescribe or diagnose. Don't let the title mislead you. Please don't try and educate your doctor about what you learned in this presentation. That may seem really obvious, but to someone on the spectrum like myself, it's not. So I figured there may be a few of you out there that would have the same thought. And this information is meant to empower a sense of self-advocacy and the ability to ask intelligent questions if you're on the spectrum and having health problems. We'll get to why this is so important in a few slides. Okay. Okay. Anyone who has a sci-fi special interest, these are the two Doctor Who's, or two of the many Doctor Who's. Autism rule number 1, talk about autism. If we aren't talking about it, we can't raise awareness. If we don't have awareness, we can't get to acceptance. So it's really important that we don't put a stigma around this diagnosis, because that's what keeps things from shifting. And it's a different brain type, it's a different neurotype. There's no reason why there should be a stigma. There's not a stigma around people who have diabetes. It's equal. Okay, here's what we'll kind of cover today. So I've got everything kind of broken down into small sections. First one's barriers to care, common medical issues for folks on the spectrum, blood work and screenings, depression and suicide risk, best types of therapy for people on the spectrum. I'll talk more about that later. And then the MTHFR genetic variation, which there's a reason I'm bringing that up. Get to that one at the end. It'll hopefully be exciting. Okay. Whenever I start a new section, I start it with a video. Oftentimes it is someone who is on the spectrum. And just to give you a little introduction, this young lady is like an Instagram, YouTube kind of influencer person. She's on the spectrum. She's high masking. What I want you to watch for is she's making a phone call. This is one of the barriers to care, is having to call to schedule an appointment. So I have this in here so you can see. Someone might sound 100% calm on the phone, but what happens before that call and what happens after that call are very dysregulated. So let's see what Paige has to say.
I'm at a hotel and I would really like breakfast. And I've never called the hotel or asked for room service before, but I think that I can, because I've looked at what I want for breakfast and it says all I have to do is I can dial star and then I can say what I want and then they'll send it to me. And I'm autistic, if y'all are just seeing this for the first time, I don't know. And so this is weird. Oh my god, that's so nervous. Okay, I'm gonna do it. I wanted to take a video. Okay, dial star, and then I say that, hi, can I get, could you send a yogurt parfait up to room 3003? And I bet they'll say, yes, ma'am. And I'll go, okay, thank you. And that'll probably be it. Okay, I pick yogurt parfait. That's all I want. Yogurt parfait, room 3003. Okay. Pick it up.
There's obvious anxiety there. And check out her voice changes.
Hi, I was wondering if you could send a yogurt parfait up to room 3003 for me this morning. Could I get a coffee, actually? Milk, please. Thank you so much.
Sounded 100%.
I did it, and it's coming on TV, and it's fine. And no one's mad at me already. Oh, that was awful.
Okay, so she implemented a few things here. Like, she decided her goal, which was out of her comfort zone, but she decided to try. And then she social scripted what she wanted. She said, okay, they're going to say this, and then I'm going to say this, and that's how it's going to work. This is the kind of social scripting that needs to be done before we go to doctor's appointments, which is one of the reasons I showed you this. And also to highlight the fact that it is not easy to make those calls. So many of us, if we have a couple failed attempts, just stop trying. So yay for Paige, she did great. 80% of autistic adults report difficulty accessing medical care. So many people on the spectrum don't drive or are uncomfortable driving in new environments. These are kind of some reasons why, potential reasons why. Making changes to your normal routine to schedule an appointment can be dysregulating. Some of us have a very strong response to change. And if the only doctor's appointment that's available is 6 weeks out on a Tuesday, and Tuesdays when we go to group, I don't want to go on a Tuesday because Tuesday I go to group. So it may be that that person doesn't schedule because it doesn't fit into their paradigm of what their schedule should look like. And having to make multiple phone calls and navigate automated menus without understanding the choices can lead to not making follow-up appointments and not making appointments with specialists if you're referred out. These automated menus are my nightmare, especially when they have like 8 choices and you're like, well, I didn't think any of the first 7 applied to me, but the 8th one didn't, and now it wants me to pick one, and I don't even remember what the first 3 was or were. So oftentimes I'll have to call 2 or 3 times, write down the choices, and then I'll call a 4th time to actually know what to pick. It's doable, it's just not fun. It would be much helpful if someone would be willing to be there with me or even make the call. The waiting room can be a barrier to care. So these 2 pie graphs are the percentage of patients who reported waiting room environment was a barrier to care related to sensory issues. For our neurotypical folks over here without ASD, we'll see 8% of people found the waiting room a barrier to care. For folks with ASD, 51%, it's more than half of us find the waiting room. We haven't even gotten to the doctor yet. We're already being bombarded and overwhelmed from a sensory perspective. That's a barrier to care. I don't want to go to the waiting room can be what I don't want to go to the doctor actually means. Here's barriers to care once you're in the office. Filling out the paperwork in the office. Maybe others don't have problems with this, but like there'll be a section for previous medical history or list medications that you're on. It's always like 2 lines that are like that big. And it feels bad because I don't have great fine motor skills. I have not had OT. And B, I can't fit everything in those 2 little sections, and then I get frustrated, and then I have a harder time focusing. My recommendation for that is to see if you can download the paperwork from the website, call and ask it to be mailed to you, and or I've done this, just drive by the doctor's office and pick up the paperwork. Do it at home. It's one less thing to have to worry about. It's one less thing to put stress on you. There are going to be a lot of stories in this section because I've obviously had issues with access to healthcare most of my adult life. In the US, the average doctor's appointment, what the insurance company reimburses them for, 7 to 15 minutes. Okay. 7 to 15 minutes is not enough time. And like these doctors don't have bad intentions at all. The prescribers don't have bad intentions. It's just not enough time. Like, how could you even go over someone's who's on the spectrum, who's on a lot of meds? You can't really like check into like, are your medications working in 15 minutes, let alone like if you're there for another issue. So I'm gonna tell you a little story just to share in case other people have had this experience to kind of normalize it. This one's about me. I guess it was a couple years ago. I had been seeing a physician that I liked, but this was a MAHEC, so like a training facility. And so that doctor was rotating out of his training to become like a hospital doctor. So they rotated in another new doctor, and they said I had to come and establish care with him. I had just seen my old doctor that I liked like 5 weeks earlier, maybe. So it seemed dumb to have to come into the doctor's office when I don't have it. Like, why am I even here? And I was like, actually, I need refills on like my anti-nausea medicine and my migraine medicine. So I'll just like, that's why I'll go and that'll be the thing I try to accomplish. So again, I had social scripted out what I wanted to have happen. The first thing this doctor said when he walked in the room was that my medications were wrong, my mental health medications. And I said, oh, I have a psychiatrist that went to an Ivy League school that I've been working with for about 10 years. So I don't really want to address my mental health medications. Then he told me one of my medications wasn't on label for depression, and it was since 2019. He just wasn't keeping current with it because it was a med that isn't used very much. That's fair too. Like there's so much information for prescribers to know these days. It's impossible to know everything. So I said that, and then he handed me a depression screener to fill out. A, it's a depression screener based on 2 DSMs ago, and B, I just told him I don't want help with my mental health. So I said, I don't need to fill this out. And he got very angry at me. He said, you're not letting me do my job. You're resisting care. I can't do my job. And at some point, he's looking at my chart, right? It says I have autism at the top. And then he was like, if you're it's like you're just alienated and you're not even picking up on my social cues. And it was like, dude, I'm not picking up on your social cues. I have autism. Like you have, it's just not going to happen. But anyways, it was interesting because as I left, and it was very hard to stay in the room. I'd stood up to leave at one point, but then I was like, oh, I need refills on my migraine medicine and my stomach meds. But as I was coming out to the front desk, and the front desk person is adjacent to the room that I've been getting my exam in, to her benefit, and I really liked their front desk person. She was like, she heard him screaming at me. It was that loud. And she was like, you don't want to schedule a follow-up, do you? Like she was advocating for me in her own way, because normally what I do after an appointment is make a follow-up. So I was really glad that she kind of broke that cycle. So I say this to say, even with all the information that I have about autism, I still had a barrier to care. So if you come into these situations and you're not doing anything wrong, these are just things that happen sometimes. Other things, we could be hyper or hypersensitive to pain, which means a doctor could misinterpret our symptoms. Like if someone says, grade your pain on a 1 to 10 scale, with 10 being the worst pain you've ever felt. We're very literal. Like we may be hurting at a level that a neurotypical person would call an 8 and call it a 5. So what that does is it makes it look like we're med seeking. We're looking for pain meds, because why would you want meds for a 5? But for us, like a 5 is very uncomfortable and dysregulating. It's hard on our nervous systems, and it's creating a lot of imbalance. And then we've gotten turned down for help. So again, this is a cue that's often read wrong. We're known to react differently to medications, and most providers not used to ASD patients will be dismissive of this and label us as difficult or thinking we know more than they do. Again, I'll use myself as an example. As a primary care doc, I've switched so often. As a primary care doc that I wanted some help with sleeping. 80% of us have sleep issues. And he was like, well, let's just start you on some Vistaril. So Vistaril is in the same drug class as Benadryl, and Benadryl traditionally is very sedating for people. There's a section of us on the spectrum that have the opposite response. And I was like, Benadryl makes me have to clean the whole house. And we're talking like ammonia in a Cool Whip container and a toothbrush clean the whole house. Like, I can't. And he was like, well, I'm not going to write you for Ambien. And it was like, so again, I was being seen as a drug seeker because I didn't want the thing. So I got the Vistaril script filled, and I took it once, and it made me awake all night, and I never took it again. So that is a barrier to care, not being believed when we express what's true for our own bodies. And mind you, it's not how anyone was educated. They were educated to not believe us. So no one has bad intentions. It just forces us to have to work harder. They ask us open-ended questions. that we're not sure how to answer. Like this is on one of the depression screenings. Have you ever been worried you're drinking too much? Okay. I'm as literal. It's a barrier to being on the planet, the level of literal that I am. So for me, for this, it was like, well, yeah, one time I was at a party and I thought if I had a beer, I'd be able to stay at the party because it would calm my nerves, but it didn't. And so then I needed to leave, but I couldn't leave because I just drank a beer. So I drank too much. So I would say yes for this. I had one beer and I'm answering yes to this. That's not what they're asking. So the screeners aren't made they're made by neurotypical people, and that's fair, but it often means they aren't hearing what we're telling them. All right, more in the office. High sensory arousal environment, everything about the doctor's office. We have fluorescent lights, we have televisions, we have strangers, we have to interact with multiple office staff, sometimes without knowing the role. Like, do I tell what's going on to the person who's taking me back and getting is this a CNA? Is this a NP? Like, what is happening and who are you? It's just very unfortunate. Obviously that's hard for everybody. Being asked to describe pain. One of the symptoms of autism is difficulty with even narrowing down where pain is in our bodies, like identifying the emotion. So being asked for us to describe pain or identify it, how we feel about it, it's something that's going to take us a minute. Again, we got 12 minutes. So this is why I recommend having a person that is on point as your person that's going to go to the doctor with you. And what you want to do with that person is plan. Okay, I have pain here and here. And then I suggest Googling types of pain and just try to talk it out with your support person as to which kind, like radiating, and they'll explain to you what that means from a neurotypical perspective. Sharp and jabbing. There's so many different kinds, and I freeze up on this question. It's like, I don't know, and that makes it seem like it doesn't hurt that bad. And then not being given enough time to answer questions. This is another one that's difficult. We got 15 minutes in there, so it behooves the professional to go as quickly as possible so they can address as many issues as possible. But most of us learn in a way that information sinks really deep, and then it correlates to other things that we know, and that takes a minute. And it's doing that, and then we formulate our response to something. So it's just not. It's another reason to have it social scripted out before you go. Okay, this is the whole point of me doing this presentation, because this is not okay. We can do better than this. The average life expectancy for an autistic person is 36 to 54 years old. Okay, the average American's life expectancy is 76. This is not okay. It's not okay. We need to learn how to access healthcare easier. And ideally, healthcare providers are wanting to know. I have a couple of healthcare providers, both virtual and in person, that wanted to know, and I appreciate that very much. The two top causes of death are premature cardiovascular disease and suicide. With suicide, there are two gaps. 18 to mid-20s, there's a high spike in those of us that commit suicide. And then there's a spike again in our 40s, early mid-40s to mid-50s. There's a huge spike again. If we make it to 60, our lifespan converts to that of an average American. So times to be very tuned in to the person, your loved one that is on the spectrum, or these crucial developmental stages where we're starting to learn as a teenager. Wow, I went to school and to college, and it was really, really, really hard. And all my friends are moving forward and I feel isolated and alone. Or in our 50s, where we look around and it's like, I'm not married and I don't have kids, and I don't know anyone else who's not married and doesn't have kids. what am I going to talk about with these people? So like, that's why those are where the peaks are. All right, common medical issues for folks with ASD. This is a medley of pictures of me getting medical treatments. Let's see, here I'm getting IV infusions of something called ferriheme for low iron. My iron was so severely depleted that they literally had to give me medication that stimulated my bone marrow to make red cells. I think this was another one of those. I had to have it done. I had it done once. It's two infusions over 2 weeks, and then about 10 months later, I had to have it done again because everything was the numbers were in the toilet again. And so that led to getting an endometrial ablation to try to see if that would help. I had this done at Park Ridge Advent. I had a great experience there. Everybody was wonderful. And then, yeah, so but we'll talk more. There's a lot of this. Oh yeah, this is me being in the hospital for hypertensive crisis. So again, there's that cardiovascular disorder. Let's talk about some conditions. There's 2 slides of this. Conditions that are super common in autistic adults, more so than in neurotypical people. We also have some good news. The good news is only 5% of us have dementia. Some of that's because our average life expectancy is 36 to 54 years old. So we don't get that far, but it looks good on paper, doesn't it? Keep in mind with these numbers, these folks are medicated. So some of the symptoms are going to show lower than they actually are, like this one. Depression being 28% is likely because they're comparing it to when they weren't medicated. I could guess the anxiety is actually much higher too, but 43.4% have anxiety. There's the sleep disorder thing. 85% of us actually have sleep disorders. That's a lot. That's most of us. That's problematic. Like, depriving someone of sleep is considered by NATO a form of torture that you're not allowed to do. It's so dysregulating for the system. And then GI disorders were 50%. I think that number's probably a little higher now, but we're going to talk about leaky gut syndrome. We'll kind of come back around to that when we get to the genetic mutation. But leaky gut syndrome is a cluster of symptoms centering on digestive issues like abdominal pain, bloating, gas, and diarrhea. There's evidence of a link between leaky gut syndrome and mood imbalances, as well as a range of immune system disturbances. I can tell you if you're in this area, I don't know how many people I've seen for these symptoms. I definitely have seen, I won't name the practice, but specialists, they just want to scope you. Just want to scope you, that's all they want to do. Yeah, I've had like supplements have given me relief from this in a way that no medication they've tried ever has. So, neurological disorders is about 56%. Epilepsy is at 25%. Half cardiovascular disorders at 49%. Cancer, again, super low incidence, but also likely because our life expectancy is shorter. And then immune conditions, you'll see at 70%. I don't know if you remember when the COVID boosters came out. People with developmental delays and disabilities were allowed to get them first before the general public. This is why, because we're more susceptible to those things. And not just like catching colds, we're also more susceptible to autoimmune conditions like celiac disease, RA, lupus, type 1 diabetes. I will say with epilepsy, we see epilepsy more in our level 3 folks. Like the level 1 folks rarely have epilepsy. At the same time, with depression, it's the opposite way. With suicidality, we see our folks with level 1 autism kill themselves at a very high rate, whereas our level 3 folks, that doesn't happen as much. Blood work and screenings, there's a little video here.
From your blood, doctors can tell a lot about what's going on inside your body. A blood test is usually pretty quick. Your mom, dad, or another adult can be with you. If you want, bring something that relaxes you, like a book, video, or music. First, a vein needs to be found. Veins look like light blue lines under your skin. After the right vein is found, a wide elastic band will be tied above the vein. This usually makes the vein stick out a little. Next, your skin will be wiped clean to get rid of any germs. You can watch the small needle go in or look away, but you have to stay very still. You'll feel the needle go in, but only for a second. Your blood will begin to flow from the needle through a thin plastic tube. It can take only seconds to fill a tube. Sometimes, more than one tube is needed. It might look like a lot of blood, but it isn't. You may feel it when the needle comes out, but it won't hurt. The spot where the needle went in will be covered with a bandage. Guess what? You're done. From here, your blood goes to the lab to be tested. Your doctor will get the results and share them with you and your parents.
Let's hold on that for a second. The reason I show this, and also that I show something that's made for children, is that those of us on the spectrum like to know what's going to happen. We ask a lot of questions in general. And in general, people in a doctor's office are so friggin' busy, they don't like being asked a lot of questions. So this is like a breakdown of what happens and why. And I did also want to say that little part where they say we send the blood off to the lab, we get the results. Sometimes that process can be 2 or 3 weeks before you get your lab results, and it takes that long for the lab to process them. If it's been 2 weeks and you haven't heard back from your physician, please call the office. Again, I know, or have your support person call the office. Sometimes results get lost. And there's just so much going on in a medical office and so many emergencies that we want to make sure that a little bit of this is on us. With those ferriheme infusions, the doctor said, okay, we'll set you up. We'll get them going. I waited 6 weeks for them to call me to set them up. And when I called, they were like, oh, you weren't in the system. So things get lost, things get missed. Like, just be aware that that's the reason. And nobody's trying to do anything bad to you. It's just a convoluted system. All right. Blood work and screenings. These are some suggestions. Again, I don't recommend you go into your appointment requesting them, but you may want to request having a conversation about them. Question?
Would this be also applicable to young kids?
100%. Yeah, these with the things that were more common in folks on the spectrum, the older we get, the more common they get. But with this one, it's unlikely you're going to see it in a 4-year-old, but at 11, 12, like at that point, these start to be applicable. Thank you. Good question. So anemia, we talked about my own experience with that, which is just low iron. I don't know if you remember from the video we just watched, but one of the little vials of blood that the lady drew had a purple top. That purple top tube is called a CBC, and it's pretty general for them to be done at like yearly checkups. And that has something, it measures your iron. It has both the H and H, the hemoglobin and hematocrit. So if you're anemic, that CBC tells you a whole bunch of stuff about what's going on, but it can also tell you if you're anemic. So hopefully that's something that's getting drawn in your regular checkups. Low vitamin D, unlike these ones that we standard pull, low vitamin D is a tube all to itself. It's a test all to itself. Oftentimes it can't be done in the doctor's office. We have high incidence of low vitamin D. So if it's the winter time, we get most of our vitamin D from the sun. If it's the winter time and you're not getting outside and your mental health is getting worse and worse and you're getting depressed and you've had your medications upped and it's not helping, it'd be good to go to the doctor and like check in on this and just see if they're open to like drawing a little bit of blood work for you. Again, I know this is all going to the doctor more, and we want to go less, but we got to do something about these numbers. We got to get it up there, our life expectancy. Also, we have low B6. So again, you see the B vitamins are often depleted. B6 helps in production of these two neurotransmitters, serotonin and dopamine, which are correlated to, well, we think they're correlated to depression and anxiety. They're actually, the serotonin model of depression is kind of on the way out. I won't get too deep into that. And then low magnesium. Magnesium maintains nerve and muscle function. And here we go again. It helps to regulate the heart's rhythm and blood pressure. So cardiovascular disease. These are the things we can do something about. We can do something about the cardiovascular disease. As you know, with our doctor, the suicidality is more of an internal journey, but getting these things checked is a good idea. These are a few more. Low B12. They can impair the brain's ability to detoxify itself and cause neurological damage. Birth control pills deplete B vitamins. They deplete, I think, 6 of them. I may have added I think I did add some information on that. We'll get to that in a second. Hypothyroidism, go ahead and Google it. I don't encourage people to Google health things in general, but if you're having weird symptoms, Google hypothyroidism. If you're feeling like, okay, maybe. Again, schedule an appointment to check in with your doctor. I don't know, there's some different agendas on this. Most of the time, the doctor will pull, or the prescriber will pull a CMP or BMP, which is another one of those tests that has a whole bunch of information on it. So that's why they're using it, because you could get, you know, a whole lot of other data on it. But the way it tests the thyroid function is it's not as good as a free T4 or a T4 index. You'll feel.
I was just going to tell you that we would actually start with the TSH. So CMP and BMP is like your kidney function, liver function, electrolytes. You have to add. TSH is a separate one. Then if you saw something off there, you might go into free T4, but TSH is what you're going to be your.
Thank you. It's good to see we've got medical people in the room, folks. Things are changing already. So yeah, I stand corrected on that one. It's been a while.
Together. That's probably why you did. Often that'll be like this. Yeah.
That makes sense. And then the last one is low glutamine. Glutamine is an amino acid that can help prevent leaky gut syndrome. What? We have a high incidence of leaky gut syndrome? What? We have low glutamine? Maybe that's correlated. For everyone, neurotypical, neuroatypical, it doesn't matter. Prolonged exposure to stress can lower glutamine levels. So for people who are very stressed out at work and just popping Tums, that could be correlative, maybe not causal, but okay. No one likes talking about it, but it's one of the top 2 leading causes of death for our people. So we are going to start with this John T. Fellows introduction to depression and suicide risk.
The most dangerous idea we have about suicide is we shouldn't talk about it. That if we ask someone if they're suicidal, it might make the problem worse. But that's just not true. Talking about suicide doesn't make someone suicidal. There's decades of research on this. People become suicidal because they experience intense stress, suffering, and agitation. Thinking about suicide creates a sense of control in a situation that otherwise feels uncontrollable, intolerable, and everlasting. When you ask someone if they're suicidal, it lets them know that you see they're in pain, that you care, and you want to help. This alone might help save their life. If you're concerned about someone, if they're acting differently, or if something doesn't feel right, ask them if they're thinking about suicide. If they are, here's what you should do next. If they have access to something they can use to end their life, ask them if they can temporarily get it out of their home. Being suicidal makes you more likely to act on emotions, and increasing the safety of someone's home can help them get through this dangerous time. Help them avoid drugs and alcohol. Both can make it easy to act on the thought of killing yourself. Encourage them to talk to someone that's in a position to help. Call a suicide hotline together or an emergency telephone number. Go with them to the nearest emergency room. For more information about the warning signs for suicide, resources for people who are suicidal, and research on suicide prevention, check out the links in the description below.
Sorry. Okay, so this is one of the reasons why depression and folks on the spectrum gets missed. Well, it's not one, it's a slide about. These are the traditional depression symptoms. Thoughts about failure, hopelessness, and death, increased self-criticism, sadness and crying. This one's not a good indicator. A lot of us mask. We've been taught to mask our whole lives. We're not going to cry when we're talking about it. So it may look like we're more okay than we are. Loss of interest and pleasure in activities. Well, a lot of us, when we're in sensory overwhelm, we don't have any interest in like leaving the house. That's kind of a bit of a baseline for us. So that's not a great thing to screen for us. Social withdrawal and lack of motivation. Again, not a great thing to screen for with somebody on the spectrum. Social withdrawals, to some extent, if we're overstimulated, is something we're going to do until we get re-regulated. Increased problems with sleeping and eating. Okay, we saw the data. We have problems with sleeping and eating. 80%. Like this is not a good indicator. Ability to be independent with fewer tasks. Maybe. By definition, autism means you will need continual lifelong support in some area of your life. So I feel like this is a question that's likely to make someone who's feeling suicidal or depressed more depressed. Yeah, I can't do anything for myself. You know, that kind of all or nothing thinking that is a cognitive distortion that comes along with depression. Okay. So depression and ASD, what can we do better? The autistic community is 4 times more likely to experience depression. Here are some depression symptoms that are specific to people on the autism spectrum. Changes in their pattern of interaction with their special interests. Could be greater, could be less. Normally, they want to go walk so they can play Pokemon Go whenever you will take them. And they haven't done that in a while and they haven't asked. We could get new special interests when we age, but if there's not a replacement special interest, this is a depression symptom. Increase in repetitive or ritualistic behaviors. So maybe someone who usually just stims when they're anxious is also stimming at the dinner table or in just family situations. And or the stim is more pronounced, I'm exaggerating. Or if it's a rocking stim, instead of just rocking, like they'll rock until their head touches the ground. So watching for increased stims. And again, stims are good. Stims provide dopamine for our brains. Stims are our body's attempt to try to regulate itself. Respect the stim. Just if it's getting to be like, if they're having to increase the stim, it means that they are having more depression, which is the only reason why we would watch that. Irritability, I don't know that this is a great indicator. Irritability, if you're asking us to do something that normally we can do, maybe would be a better indicator. Increased social isolation. The way that I would see this for folks on the spectrum would be pulling away from supports. If I just can't go to therapy. I would say maybe one of those, and I would ask the therapist if you could have a virtual session next session. When they're pulling away from supports, that's when they need help most. And then the last one is regression or decline in self-care. And regression is oftentimes more obvious as far as like, you've been making yourself breakfast for years. Why do you want me to do it? Not that all parents would say that, but just like that's an example. This is important. People talk about suicide hotlines a lot. Okay, great, but we're using the phone again. That's a barrier. This is the text hotline. It's just a crisis line. So you don't have to be suicidal to use it. You can just be dysregulated. You text 741, 741. You text the word home. It's 24/7. And they will wait a minute, and then a therapist will come on, and you can have a text conversation with it. For those of you that have kiddos, young adults, I suggest doing this with them over small things. Like, I thought that person at school was my friend, but he said he didn't like me. He just wanted to play with my Xbox or whatever Xbox is all, but whatever the kids are doing nowadays. You know, be a parent and also sit down and like say, we're gonna text this. I'm gonna show you how to text this number, and we'll see if this person can talk to us. And then if you feel like you can't talk to me, which is gonna happen when they hit puberty to some degree, it's normal developmental stage. They know that they can find somebody that can help, that they can talk to. Okay, I love this lady, Katie Higgins-Lee. I use a lot of her work. This one is kind of quiet, so we'll see if we can turn it up, or you can read it's subtitled on the top. But she's great. I just emailed her the other day.
I recently posted a video listing some ways that therapists harm autistic and ADHD clients, and I think the comments, specifically on Facebook, should be required reading for therapists, because most of the comments are people sharing their personal stories of being harmed by therapists. However, there was one comment from someone saying that harm is not the correct word and that these experiences were instead just misunderstandings. No, I used the word harm on purpose. Therapists, including me, need to recognize that our lack of adequate training can harm clients. Intent is different than impact. Prior to discovering that I am autistic and an ADHDer, I unintentionally harmed clients because our education is so lacking in this area, and much of our education is based on neuronormative ideals. The actions that I listed in that video cause harm in numerous ways, including 1. Causing clients to conclude that they are broken or incurable. 2. Causing clients to be incorrectly medicated for an inaccurate diagnosis or not get needed medication. 3. Treating clients with behavioral therapies when a sensory issue is at play can literally cause PTSD. And 4. Many autistic and ADHD clients experience these types of things in therapy and then determine that therapy isn't a safe place and decide to never try again. That is harmful. If you are a therapist and you don't understand autism and ADHD, please seek out additional training from people who have lived experience. You have autistic and ADHD clients, and if you can't recognize this, you might be harming them.
Love Katie. I don't think we,
I recently
so what we're gonna go into is, so what kind of therapy is good? Like, you're telling us what's not good, what is good? So this data is from Spark for Autism, which is the biggest United States conglomerate of information about people on the spectrum, mostly collected from people on the spectrum. So it's kind of lovely that way. Information that Spark is researching now is not gonna hit medical textbooks for at least 7 years. So it's not going to be trained. So that's why I'll have on my website, which is www.theautisticautismconsultant.com. I have these all listed there, so you don't have to like rush to write them down, because I'm going to go through them pretty quick. For adults and adolescents, acceptance and commitment therapy, mindfulness-based cognitive therapy. That's where you'd slide in the CBT and the DBT. It's not perfect for everybody, but it can be good. Accelerated resolution therapy. This is what I've worked with therapists for years on. And it was really helpful. And then my favorite is internal family systems, which is the idea that there are all these different parts of you that are inside of you and how you can integrate them and pull on them, and that it's very good for this on the spectrum, because it's like math. You know, it's very specific and there's reasons for everything, and you don't have to figure out like how you feel at all. It's just like identifying things, like that's a water bottle, that's another water bottle. So yeah, internal family systems rocks. So if you're looking for a therapist on psychology today, you can look and see none of these things are taught in basic therapy. A master's of social work and therapy, licensed mental health counselor. This isn't standard practice. So anyone who is accelerated at these things or knows about them has had extra continuing ed in it. And then medications from an experienced provider for both adults and children of a certain age. It's good. Kiddo therapy. Okay, I am not going to talk about ABA. I'm not going to do it. That's another presentation. If I get started, I won't ever shut up, and we're going a little long. Here, real quickly, floor time, relationship development intervention, pivotal response treatment, social communication, emotional regulation, transactional support, play therapy. There's lots of different kinds of play therapy. Parent-child interaction therapy. Notice how all of these are teaching the child how to respond to another human versus teaching them to hold the fork the right way or to, I don't know, like the things that are traditional behavior modifications that are about trying to get someone to stop doing something that's organic to them, like stimming. This is not about stopping stimming. This is about how do I connect with people that can support me. So hooray for Spark. And again, this will be on my website if you want to check it out. All right, this is the last part. Y'all hung in there good. We're going to talk about the MTHFR mutation. It's important. A lot of us have it. A lot of the general public has it. It's estimated, well, we'll tell you. But we're going to talk to or listen to Dr. Will Cole for a minute. This one's loud.
So MTHFR is the acronym it's the enzyme that converts folic acid into folate. And why is that important? Why is this B vitamin activation so important? Is because it's a major methyl donor, which is a carbon-hydrogen CH3 group that basically allows methylation to run. And methylation is this big biochemical superhighway that makes our brain healthy, our gut healthy, our hormones healthy, our detoxification pathways healthy. So MTHFR gene mutations, just like any methylation gene impairment, you can have one mutation or two mutations. And the two mutations, the double mutations, are at a higher risk for the body not methylating so well. So it can significantly inhibit how your body methylates, which is super important. It happens 1 billion times every second in our body. So this is linked to, in some studies, that are correlating that with MTHFR mutations and autism spectrum disorders.
Okay. So that was a lot of words. We're going to make it a little easier. Basically, this variation genetically means your body can't process folic acid, which is a type of B vitamin. So the B vitamins are good for regulating your brain, heart, wow, premature cardiovascular disease, and your mental health. If you have this genetic variation, you're very likely to have issues with your B vitamin levels. And I'll ask Kat to correct me if I say anything medically wrong in this part. So it's thought that 30 to 40% of American population has this genetic variant, and studies have shown that people with ASD are twice as likely to have it. So 60 to 80% of us likely have this, which is why you can get tested for it, or you can just assume that it's something that you have and make a few adaptations. We're going to go into those. These are the symptoms that low vitamin B levels can cause. Anemia, wow, look at that. Nausea, stomach issues, here we go. Confusion, depression, memory issues, fatigue, hallucinations, although I'll say I've never seen that one. And then aggressive behavior, which I have seen that one. So these are all kind of mental health symptoms, but they're mental health symptoms from a physiological cause. So if a medication's not working, or if none of them are working, like you've been shifted meds every 6 months for 15 years, it may be time to start looking at some potential physical causes. Sometimes, yeah, there's different kind of doctors that can help with this as well, if you can afford to pay for them. How do we minimize the effects of the MTHFR? Well, we avoid folic acid blocking drugs like birth control. For some people, we need birth control. Gender dysmorphia is very common with people on the autism spectrum, and having your menses be predictable and cyclical can help diminish that gender dysphoria. So we don't want to take our birth control pills away from those folks. What we want to do is find a vitamin that doesn't have folic acid in it and give them that. You want to avoid antacids because they block the absorption of B12 and other nutrients. Remember, we tend to have low B12. Eliminate gluten from your diet, especially wheats. Avoid GMOs. There's a lot of, you probably all know this already, there's a lot of reading ingredient labels involved in being on the spectrum. It's not mandated legally that people have to label their foods as having GMOs, but we're seeing a whole lot more bioengineered food ingredients written in the ingredient list. So read your labels. You'd be surprised. Just because it came from Whole Foods doesn't mean it's not genetically modified. So this one's important. We're going to limit the intake of processed foods. It's hard, I know. And then anything that's labeled vitamin enriched or fortified, there are foods that have vitamins added back into them, and often folic acid is one of those things. So we really want to avoid those two. Vitamin enriched and fortified. We don't want to do that. Sounds like it's a good thing, but often it's not. So we don't want to take a multivitamin with folic acid in it, although a B multivitamin is a good idea. If anyone is having a hard time with finding a vitamin that doesn't have folic acid in it, shoot me an email, and there's one I can send you a link to. It's I'll give you a discount code. It ends up being like $20, and it's a 2-month supply, and it does not have folic acid in it, so it's pretty inexpensive thing to try to see if it helps. Okay, conclusions. Y'all made it to the end. Well done. Sometimes it's hard to differentiate between mental health symptoms getting worse and physical issues making the mental health symptoms worse. If you're in a place where you've had mental health medication tweaks and still aren't finding any relief, like this is what over and over and over and over and over again kind of scenario, you might want to explore some of the things we talked about with your doctor or your NP or your PA or whoever you see. Personally, I probably shouldn't say this, but I recommend NPs. They've been nurses. They actually talk to patients for more than 10 minutes. Consuming healthcare of any sort is very difficult, period, but even more so for those of us on the spectrum. Use your supports. Use the people that love you. Use a paid support. Use a neighbor. It's not being less than. This is a hard system to navigate. It's hard for the prescribers too. They're not trying to be mean to you, except that one guy, but maybe he had a reason. No matter what your age, people on the spectrum need to have a healthcare advocate. That's somebody who does the pre-planning, the scripting before you go and goes with you to take notes. You can request when when you go to the checkout window after your appointment to get a copy of the visit note or the visit summary. Most of the time, if they're not busy, the office manager, whoever's up front, will print it out for you. I do this whenever I can because very, very often what I think I have communicated is not what has been heard. And don't make a big deal about this. Don't demand to see the practitioner again. Just log on to the portal, send a message to the portal that's, hey, this is, you heard me saying that I've been having difficulty sleeping the last 2 weeks. I've been having difficulty sleeping my entire life. Just wanted to clarify that in case that made any different. Don't be afraid to change providers if your practitioner isn't listening to you or makes you uncomfortable. This is hard because most of us don't like new people. Mm-hmm. New people that aren't our friends, at least. My recommendation on this is a few things. One, look up, post on Facebook, Reddit, your social media outlets where you can communicate with other people on the spectrum, or where the parents are communicating with other people that have kids on the spectrum. Ask which providers work for their kids or for the other adult. There are certain people who are prescribers that have a kid on the spectrum. I guarantee they've done a whole lot more research into this than your average prescriber, and they're gonna know how to not be dismissive, because what's dismissive to us isn't necessarily dismissive to neurotypical people. So we're right at 5:36. I appreciate you being here and wanting to know more about this. If you want any more information or if you want a copy of the slideshow, I'm happy to send it to you. Just shoot me an email. And understand you do not. Ask questions you should. So the chat is disabled for privacy.
It's not. No.
Okay, so you can either chat, apparently we have enabled the chat now, or you can text questions. This is my work phone. And if anybody in the room, maybe we'll do like 10, 15 minutes of questions, if there are questions. And again, it's okay. This was a lot of information.
You've got about 8 minutes of the meeting time online.
Okay, we can add some more to that.
Here's-
Does anyone want to ask me a question from behind me?
I have questions.
I like people who have
Questions.
Oh,
questions.
That question was something about, is methylfolate okay or something?
Yeah, absolutely. Oh, I see. Great.
But yeah,
Jack,
my
question.
question
That
is,
is
that is the question. Is methylfolate okay? And you're saying yes, it is.
Is methylfolate okay? Can you expand on the question?
I think it's a type of.
Yeah, no, like okay in what sense? Oh, to like have in your B vitamin? Is it methylfolate the active form of folic acid?
That I'm not 100% sure of. Sounds right, but
I'm pretty sure that methylfolate is what folic acid metabolizes to. If you want to shoot me an email, I will absolutely 100% find the actual data and let you know. Sometimes I don't have answers, but I am happy to go look for them for you.
Oh, Leanne said L-methylfolate is, oh, whoops. Sorry
For disclosing your
L-
secret identity.
L-methylfolate is fine with the MTHFR gene variation.
Okay, thank you.
Yeah,
That's,
thank
one of our
you.
prescribers that is amazing at her job and really good at working with people on the spectrum.
And
So
also says it is the intermediate product the brain isn't able to synthesize, so it is what you would need.
okay, great. So super helpful. Look at that, a prescriber, it doesn't have to come from somebody on the spectrum. A prescriber that's very well versed in this will know. And also a particular prescriber is someone who seeks out information constantly, so.
Oh, I just realized, okay, well, I guess everybody can hear that. She had actually just said it to me, but Kristen, I'm assuming you just heard everything I read out loud, so.
No idea what you're talking about.
So she couldn't see it in the chat,
Oh,
but since
right,
I was
right.
saying it,
Okay,
she can
gotcha.
hear it.
Context clues are not my jam, peoples.
So my question was also related to the MTHFR gene. So it makes your folic acid level be high?
Your body can't process the folic acid. So if you put folic acid into your body, you're more likely to experience those symptoms that we looked at, like depression, GI disturbances, aggression. So not everybody has it, of course, but if cutting out folic acid is a way, if you cut out folic acid and suddenly you're like, oh, I feel better, you save out on having to like spend that money.
I guess I'm confused about, so then you would have like free floating folic acid floating around.
It doesn't get used, it doesn't convert it to the form that's usable by your body. It just stays as folic acid instead of converting to the form where your body can use it. So it wouldn't just stay floating around, it would like get excreted the same way any other vitamin or mineral that you take gets excreted.
So then it seems like your body does not have enough folic acid to actually use.
It doesn't process it. Yeah.
So then what happens to like the places that are looking for folic acid if your body's not processing it right? Or maybe I'm like at the wrong end of the.
No, that's a perfectly valid question. It's just we can't yet do anything about that
Okay.
to make the body be able to, if you have this genetic variation. Leanne, if you're out there and you know more than I do, please, I mean, you always know more than I do, but if you can help. But yeah, that's a great question. And maybe someday we'll be able to like reverse that gene, but keeping the other B vitamins at a good stable level is what we can do to decrease the risk of like the depletion of the folic acid.
So
And perhaps based on what Leanne was saying, if you are able to find something with L-methylfolate that will, she says, yeah, it helps provide the building blocks that your body can't get from the folic acid. So that would be the kind that folks.
All about that L-methylfolate.